Hello, everyone. Welcome again to our second webinar of the year. My name is Dr. Azuma. I'm going to be the moderator for today's webinar. The topic for today is hot topics in women's health. A brief introduction of myself. I am Dr. Azuma. I'm a board-certified OBGYN and a public health professional. I serve as the chair of the Women's Specialty Group of the International College of Surgeons, the U.S. chapter. I currently practice in Maryland. I attained my medical degree from Wayne State School of Medicine and my public health training at Harvard T.H. Chan School of Medicine. I completed my residency training at Long Island Jewish Hospital. I'm excited to be here today to moderate today's webinar. I'm excited to introduce my first speaker, Dr. Hella. Good morning. Dr. Kimberline Hella was born and raised in Flint, Michigan. She's a graduate from Howard University. She then returned to Michigan State for her medical education. She completed her medical training in obstetrics and gynecology at the University of Illinois College of Medicine at Peoria. She was the recipient of the first ever Angel Award. She was also the chief resident. Dr. Heller then moved to Oregon to begin practicing as an OBGYN attendant. In 2012, she helped start the Oregon Clinic Obstetric and Gynecology Group. She's also a board member of the Care Oregon Medicaid Insurance Company. Dr. Heller is an active member of Zeta Phi Beta sorority. She's also the charter member of the local Jack and Jill of America chapter. She is a wife and a mother to a brilliant 12-year-old, and she is still a Star Wars geek. Please join me in welcoming Dr. Heller. Thank you.
Thank you so much, and thank you for inviting me.
Thank you. Okay, we'll start your presentation.
So this morning, I am going to present on ectopic pregnancies. I was actually very honored was really glad that this was assigned to me. And when it was actually kind of interesting because I had 3 ectopic pregnancies in a row in regards to patients who were coming on my ED call. So it was perfect timing. It was great because it helps me to remember and to refresh my own knowledge. So first of all, to start for disclosures, I don't have any. So we're gonna do that page first. Yeah, I don't have any disclosures. When we think about ectopic pregnancy, first of all, why is ectopic pregnancy important and why do we talk about it in the first place? We know that ectopic pregnancies account for 4% of all pregnancy-related deaths, but most importantly, ectopic pregnancies are the most common cause of maternal death in the first trimester. We know that when you define ectopic pregnancies, what exactly is it? We know that it is a fetus that develops outside the uterus. Typically, in 80 to 90% of cases, it actually implants in the tube itself. Other locations, though, are your cornuas, the cervix, in less than 1%, your ovary, in 1 to 3% of ectopic pregnancies, although this is becoming more common. You can also see them in the abdomen or on the bowel, and of course, in the cesarean section scar itself. So just a quick anatomy checkup real quick. So if we're looking at our uterus, of course, we can see that we have our fallopian tube. We have different portions of the fallopian tube, and this is important. We have our ampullary portion, our isthmic portion, and our intramural portion. And when we think about the most common place for ectopic pregnancies to implant, they tend to implant 80% of them in the ampullary portion of the fallopian tube. One of the types of ectopic pregnancy that we see very rarely, but that I want to make sure I bring up, is something called the heterotopic pregnancy. This is a ectopic pregnancy that we see where not only do we have an implantation within the uterus itself, but we also have a pregnancy that's within the tube, which is why whenever we have that first trimester ultrasound, it's important to not only look at look inside the uterus and measure the pregnancy, of course, for dating, but also to make sure that we look at the adnexa just to confirm that there's no heterotopic pregnancy. We do know that there's a naturally, if you look at the risk of heterotopic pregnancies, in a naturally achieved pregnancy, the risk ranges from 1 in 4,000 to 1 in 30,000, whereas the risk among women who undergo IVF or in vitro fertilization could be as high as 1 in 100. When we talk about ectopic pregnancies, it's important to talk about where they are in relation to the uterus, but of course, how likely some are to cause death more so than others. Because in most cases, an ectopic pregnancy can be a silent killer. We don't know it's happening. We don't know it's in the wrong spot, oftentimes until it becomes catastrophic. So when you think about the locations, and the corneal location, which remember is right as that tube is entering into the top of the uterus, these are 2 to 5 times more likely than any other type of ectopic pregnancies to end up in morbidity with the mom. Corneal pregnancies tend to experience rupture at a later stage compared to other tubal pregnancies, and this is basically due to the greater distensibility of the myometrium at that point. If you have a cesarean scar ectopics, those occur in 4% of all ectopic pregnancies, as well as 1 in 500 pregnancies in women who underwent at least one prior cesarean section. You also have interstitial or intramural pregnancies. These are 7 times higher than other sites. Oftentimes, the increased morbidity or mortality that you see is due to a higher rate of hemorrhage in these interstitial pregnancies. Of course, we also have abdominal cavity ectopics. I'm sure everyone has heard recently of the recent case report of a woman who had a viable pregnancy that had actually attached to the liver. Those are extremely rare. In this case, both mom and baby survive, but those are extremely, extremely rare, but we do see them. And of course, we have the ovarian pregnancies, and those are ones who are only 1 to 3%. They actually attach to the ovary itself, which makes you wonder if the egg actually was fertilized in the actual corpus luteum, or if it was fertilized as basically the sperm got to it just before it got as it got into the fimbriae, and if it just implanted right on the ovary. Those always are interesting, but they appear to be random. So one thing I wanted to make sure that I highlighted, because we don't talk about a lot, and it's actually still really rare, is we want to talk about that tubal segment or that interstitial pregnancy. So interstitial pregnancies they're the interstitial or intramural. They're extremely rare. Probably none of us will ever see them, although I will say I have seen one. But basically what it is, and I like this picture because you can clearly see the endometrial cavity here. I don't know if you can follow my cursor, and you can actually see the muscle layer of the uterus. So basically the intramural or interstitial ectopic pregnancy comes in. It's in the corneal region, or interstitial region of the tube itself as it enters into the endometrial cavity, and it either is able to bypass the lumen of the fallopian tube and actually go into the muscle layer itself. So typically with these, of course, you're diagnosed by ultrasound. Sometimes you diagnose them by MRI because ultrasound sometimes cannot always pinpoint exactly where it is. But most of the time when these are diagnosed, they're diagnosed at the time of treatment. So usually you start off with a laparoscope and then kind of have to proceed to open in most cases in order to fix these. But they're very, very rare, but that was really interesting because I know a lot of us don't even think about interstitial or intramural ectopics. So when we think about risk factors, like why do we get ectopic pregnancies? Well, typically we get them because there's a prior history of damage to the fallopian tube. This could be due to chlamydia, hormonal variations during the menstrual cycle, inflammation, infectious issues, toxic issues. People who undergo IVF are more likely to have this type of damage. They have increased damage to the fallopian tube. Also, advanced maternal age could be risk factors. Smoking, although that seems to be decreasing. A prior ectopic pregnancy will give you 10 times the increased risk. For those people who still remember DES is, because this is where I admit my age, that's diethylstilbestrol, which for a long time was used as a way of preventing preterm labor, but we know caused issues in the offspring of women who took it. But more and more of that generation, unfortunately, is dying off. Of course, IUD use has been for years associated with ectopic pregnancy, and then of course, REI or assisted reproductive techniques. So 1/2 of all patients who have ectopic pregnancies end up having no risk factor at all. Again, we're talking about typically if you do have it, there's some sort of disruption of the normal tube anatomy. You can have a ascending infection, so typically like your chlamydia or your gonorrhea. If you have a recurrent infection, that also can be a major source of tubal pathology. And then the biggest concern, the reason why we think that infection has an impact is because we think that infection actually alters tubal function and could cause tuber obstruction and pelvic adhesive disease. Prior surgeries can cause it. Congenital anomalies also are risk factors, and of course, tumors. So if you have a prior ectopic pregnancy, again, you have that 10 times increased risk. It increases to more than 25% if you have 2 or more ectopic pregnancies. And a lot of times it doesn't even matter if you've had prior surgery or if it's just by treatment, just the fact that you've had 2 or more increases your risk. And then of course, once we get, again, we talk about smoking, and that has continued to be a less significant risk factor as time has gone on. And even though there was um, with the original IUDs, so back when it was a lot of these Lupinidalcon Shield, those of course increase your risk. As we've had more usage of our progesterone-based IUDs, we actually do have less of them, but historically, we've said that 53% of pregnancies that occur typically occur with IUD in place. So going back to the ovarian ectopic pregnancy, I want to make sure I was able to show people kind of what that looks like. Right here, of course, is our ovary. Here's our pregnancy that is implanted on the tube. This, of course, has not ruptured yet. But these ovarian pregnancies can occur in one per 60,000 ectopics. So again, one of those once in a lifetime as a physician things that you should see. The risk is not increased with PID or prior tubal injury. It appears to be a random event. 75% of the time, women are lucky and they self-terminate. And oftentimes you can successfully treat these with ovarian conservation, which is what happened in this particular case. It was easy just to use my ligature to go right across the base of the cyst and to easily remove it. The ovary didn't bleed that much, and all it took was a simple stitch to make it hemostatic. Oftentimes, in this particular case, these are diagnosed as corpus luteal hemorrhages. So, and again, luckily, most of them self-terminate. Okay, so when you think about symptoms of ectopic pregnancy, either you can have no symptoms at all, or you could have severe nausea, severe pain, a tearing sensation. You do have vaginal bleeding. And I think the important thing to remember about this is a lot of times, especially if you're the physician on call, or me personally, I'm on call for the ED call. If the ED calls and says, well, this woman has vaginal bleeding, my brain does not initially first go towards ectopic pregnancy because that's usually a late sign. It's not an early sign. But in regards to the pain people tend to feel, it tends to present, pain tends to present between 5 to 7 weeks of gestation as the tube distends. The rupture of the tube usually causes onset of severe pain, and it's usually abrupt. One other sensation people tend to have is pressure in the pelvis, and that's usually because after rupture, there's a pooling of blood in the pouch of Douglas, which gives people that urge to defecate. Of course, we know that blood in the belly causes a lot of pain. Your body likes blood where it belongs, anywhere else it hurts really bad. It can be referred to diaphragm only because, of course, the pain is especially when people are laying down, the blood goes up to the diaphragm, causing pain. When you do have that vaginal bleeding, it can range from scant to hemorrhage. And often you can notice it from sloughing the decidua, which is why we tend to have it. But again, that's a late finding. So sorry about this particular one, but for diagnosis, you just have to get a really good history of physical. You want to make sure that you obtain your menstrual history, determine the presence of the ectopic pregnancy risk factors. And if you determine there's presence of ectopic pregnancy risk factors, that of course should increase your index of suspicion. You should start looking for it. And then of course, at that point, we start thinking that it's ectopic, start thinking about your options. So if you can look at the comorbidities, you can see if someone can actually use methotrexate, which is great because it helps to decrease morbidity, but helping to decrease trauma to the actual tube itself. You want to make sure there's a hemodynamic stability, also, so you can look for use of methotrexate. And then it's important to assess volume of vaginal bleeding. One thing I wanted to bring up real quick, because I know I'm running out of time, is a lot of times we have the whole adage of if you don't have the HCG doubling, then that's an abnormal sign. Well, first of all, I want to talk about the fallacy of doubling. The HCG does not double. It changes to less than 35% over 2 days typically. But it is another thing that can help is looking at your progesterone level. That's something that's not looked at a lot. But if you do a progesterone level at the same time you're doing your HCG, it helps with earlier diagnosis because a progesterone less than 5 is non-viable. progesterone greater than 24 is viable. Typically, progesterone levels between say 15 and 18 should increase your index of suspicion for an ectopic pregnancy. So it's just a little bit more helpful. And then, of course, when we think about the diagnosis, there's that discriminatory level. And again, the thing about the discriminatory level is it is often something that we argue about, and we find that typically, if it's less than 4,000, we know that that's more than likely right within the discernible zone. You can have your absence of your possible gestational sac ultrasound, and you can have that still within the discernible zone. I'm almost done, guys. So the treatment options are you can do your laparoscopic self-injectomy or self-angiostomy. This could be open. You can do a hysterectomy, although we try not to do that. Medical is going to be the methotrexate 50 milligrams per meter square. Oftentimes, especially in our hospitals, that the chemotherapy nurses have to give. There's a single dose and repeat dose regimen. The single dose is more successful if your HCG is between 24, 39, and 4,000. If you have bleeding already, if you have pain, prior to, if you have a heartbeat, it's not worthwhile to even try methotrexate because it's going to fail. So the question is, why does this get missed? Why do women still die? Do not discount racism. We know, of course, that Black women's pain is people don't think about it. They don't consider it. And a lot of times we get ignored. Do not discount patriarchal biases because, again, women's pain in general is often ignored. We're often seen as being hysterical instead of actually paying attention. There's also, like we talked about earlier, a tacit misunderstanding of the discriminatory zone. Honestly, if you're going to do the HCG as your guide, I highly suggest using progesterone as well as a way of decreasing the amount of time between diagnosis. And then we have, especially in the United States, we have a lot of non-physicians in the emergency department. We have a lot of nurse practitioners and PAs who do not have the same level of training as like an OBGYN resident or ED resident. And sometimes, depending on how experienced or inexperienced they are, that can also delay diagnosis and care. Again, going back to racism, as Black women, we're more likely to experience ectopic pregnancy compared to white women. This could be due to a number of different factors: delayed diagnosis of chlamydia, chronic stress, and again, our pain being ignored. And that's it for right now. I kind of got in just over my wires. Sorry about that. I hope that was helpful.
Yes, thank you so much, Dr. Heller. You're like the best person to do this presentation. Ectopic pregnancy is very serious, and like you say, misdiagnosis can lead to increased maternal mortality. I do have a relative that was not diagnosed early, and she died from an ectopic pregnancy, and 3 of her kids became, motherless. So yes, this is an important topic, not just as an OBGYN, but someone that has lost a family member because of ectopic pregnancy. Thank you again. I'm going to have Dr. Ebenezer Babalola join us shortly. Let me briefly introduce him. Dr. Babalola graduated with honors from the prestigious College of Medicine in the University of Ibadan, Nigeria in 1989. After working briefly at the American Baptist Hospital in Nigeria, he then relocated to the United States. After that, he worked so hard and became triple boarded as a physician. He's a triple board certified physician in these specialties. He's board certified in family medicine. He's board certified in OBGYN. He's also board certified in urogynecology and reconstructive pelvic surgery. In addition to all those triple board certification, he went and got an MBA from Warwick Business School, the University of Warwick in Coventry, United Kingdom. Over the past 18 years, Dr. Babalola has held various leadership positions in academic and integrated health systems. He successfully established multiple female pelvic floor centers. He has published several peer-reviewed journals on urogynecology and pelvic floor disorder. Dr. Babalola is currently a consultant surgeon in urogynecology and reconstructive pelvic surgery service at Dainet AL Emirate Hospital for Women and Children. He serves as a program director for the urogynecology department at Dainet Emirate Hospital Women and Children in Abu Dhabi, UAE. join me in welcoming Dr. Babalola. I count him, and I'm proud to say he's my mentor. He's just a force to reckon. I'm excited for his presentation today. He's going to be talking about urinary incontinence in women. Thank you, and help me welcome Dr. Babalola.
Good evening. Thanks, Dr. Iberi, for that kind introduction. And it's 9:30 here in Abu Dhabi. Nice to speak to you in the United States. Tonight, I'll be talking about urinary incontinence in women. I have nothing to disclose. After this presentation, we understand the common types of female incontinence and how do we manage it and how do we come to conclusion and introducing the advanced treatment options that was recently introduced. Then we are going to talk about prevalence, the quality of life, the risk, and the cost. Urinary incontinence is common in women. In the United States, it accounts for 25% among women. Moderate to severe incontinence occurs in 16%. Unfortunately, the prevalence and severity increases with age. In elderly women, especially people above the age of 60 and 50, it as high as 30%, and for those above the age of 65, as high as 50%. In addition, about 15% of women experience incontinence on a daily basis. This graph or this picture shows the prevalence of incontinence on the y-axis, and the age distribution. It shows that incontinence increases as women get older. With respect to incontinence in this part of the world in UAE, the prevalence of incontinence among all young women in UAE is 1 in 5. And also among women that are past reproductive age group in the UAE, the prevalence is about 40%. In general, all over the GCC countries, which are Kingdom of Saudi Arabia, Qatar, Bahrain, Kuwait, UAE, the prevalence of incontinence is about 20 to 54%. So going faster, what about the cost of or the impact of incontinence? This figure is from the United States. The economic impact of incontinence in the US population is about 25 billion. And on the average, an incontinent patient spends at least $250 per year as out-of-pocket expenses. In addition, the quality of life, both in social, physical, and sexual well-being, is affected. What are the types of incontinence? Generally, we have stress incontinence, urgency incontinence, overflow, functional, and what is called extraurethral incontinence. This picture kind of broadly, we divide them to 3. The stress incontinence are those that occur with physical activities, such as coughing, sneezing, laughing, and anything that will increase the intra-abdominal pressure that we kind of stress on the bladder. The urgency incontinence are the ones that are associated with urgency, frequency, and the popular commercial in the lay press that I got to go right now. And mixed incontinence refer to those that have the combination of urgency and stress incontinence. For stress incontinence, as we rightly say, the symptoms is usually leakage with physical exertion and is due to urethral hypermobility or weakness at the bladder neck. The risk factor for stress incontinence are aging. Is the most common form of incontinence, in women below the age of 60, obesity, COPD, history of prior pelvic surgery, and also women that has a previous vaginal birth, especially after the second or third vaginal birth, and with instrument vaginal delivery, either forceps delivery or kiwi. For urgent incontinence, as I said before, it's usually the feeling that a patient wants to feel the urge to urinate, but immediately they have to proceed to the bathroom, and sometimes they get leakage of urine before they even undressed. This could be due to neurologic disease like stroke, multiple sclerosis, and also it could be idiopathic when the cause is unknown. This is the kind of incontinence that is common in women above the age of 60. And the risk factor here are things like diabetes, frequent urinary tract infection, and age. Overactive bladder was first described in 2009, and essentially this is just a constellation of clinical episode of feeling the urge or the pressure to urinate, and also associated with either nighttime or daytime frequencies. Mixed incontinence unfortunately accounts for 20 to 40% of incontinence among women. We also have reversible causes. There are some reversible causes of urinary incontinence. Say, for instance, during the perimenopausal phase, people with atrophic urethritis or vaginitis, urinary tract infection, pregnancy, these are cause urinary incontinence, but as soon as the precipitating factor is no longer present, the incontinence gets resolved. Also, medication, especially diuretics, alcohol, can cause incontinence, as well as impair ability to, when a woman has some mobility problem to reach the bathroom. Generally, we screen for incontinence through the screening questions, and essentially we look at the brief history, physical examination, and very important, we always make sure we do urinalysis, as infection can be a cause of incontinence. Most of the questions are very simple, straightforward. Do you leak or wet yourself with coughing, sneezing, laughing? Or do you accidentally wet on yourself before reaching the bathroom? Also, we always use what is called voiding diary. The voiding diary kind of gives us a pictorial view of what has been going on when a patient is unaware. In this chart, we give out the patient to fill out for 3 days. And essentially, what patients do, they record the fluid they take, how many times they void, and how many incontinence episodes that they experienced. Other thing, we always want to find out what are the other medications like diuretics, antihistamines, anticholinergic, alpha blockers, or sedative medication that can cause incontinence. We always want to review the patient history. Essentially, like everything we do, general exam, particularly the abdominal exam to rule out the pelvic masses. And on pelvic exam, we make sure we do is there any evidence of genital atrophy, pelvic organ prolapse, and if there is any injury with the sphincter, especially in women that has previous history of either third or fourth degree vaginal tear. Neurological exam essentially to make sure there is no neurologic problem, such as multiple sclerosis, ALS, and after stroke or CVA. Quick thing we do in the office, we do urinalysis, cough stress test, and we always want to make sure we check a post-void residual, and especially in women that have overflow incontinence, which may be likely due to pelvic tumor, fecal impaction that doesn't allow them to urinate. But when they complain of leakage, it's just the overflow of the urine from obstructed bladder. This is bladder scan we do in the office. We essentially use it to check post-void residual, just to rule out any risk of urinary retention. Urodynamic testing, this is the gold standard, but it is not recommended for everyone. We always use it as when, after the patient has been seen, conservative measure has been done, and there is no clear indication for the clear indication as the cause of the incontinence. Also, people that have failure with medication or failure with previous surgery, we always make sure we do an urodynamic testing. A catheter is placed in the bladder and in the vagina, connect to a computer machine, and we kind of look at what is the bladder volume, the bladder pressure, as well as patient being free. We want to make sure there is no spontaneous abnormal pelvic floor contraction. There are non-invasive therapy we adopt in stress incontinence and urge incontinence. And essentially, these are lifestyle modification pelvic floor muscle exercise, bladder retraining, and sometimes we can use a vaginal pastries or insert for stress incontinence. On behavioral therapy, we always make sure, fluid management, especially making sure patients avoid either soda drink, alcoholic drink, or excessive caffeine intake. Also, these are bladder irritants, and they can cause urgency and frequency. Weight loss is also very important for people that are morbidly obese, and how to manage constipation, as well as to do what is called scheduled or time voiding, whereby we have a small cloth. Patients are being reminded to go to the bathroom to empty their bladder every 2 to 4 hours, every 2 to 3 hours. On pelvic floor, this picture is just a diagram of pelvic floor showing the pelvic floor muscles, the puborectalis muscle, bulbocavernosus muscle, iliococcygeus. We are specialized, a specialty trained physiotherapy that can assist in training patients about how to do Kegel exercise, biofeedback, and in some cases, we now have ability to do electrical stimulation. This picture kind of shows how the patient demonstrates to the patient when they have the urge to go to the bathroom, they stop, which is called quick fix, cross their leg, do backward canting, and try to distract their mind until they get to the bathroom. And also, in reviewing the bladder diary, we want to avoid any bladder irritant, either caffeine, excessive caffeine intake, or other medication. This is a long list of medications that are used for overactive bladder. Most of these medications are anticholinergic and beta-3 agonists. In the next subsequent slides, I will be talking about possible side effects. Essentially, when a woman presents with urgency incontinence overactive bladder, we need to make sure there is no evidence of atrophic lower genital tract. If there is, and there is no other contraindication, we try to start them on vaginal estrogen. And majority of these women will do better with vaginal estrogen and pelvic floor exercise. When this does not work, we go to antimuscarinic agent. There are different types like oxybutynin, tolterodine, trospium, and vesicare. This is a new kid in the block. They are called beta-3 agonists. This medication has no side effect of anticholinergic medication, and they are known to be more superior but more expensive to anticholinergic. The only drawback is that hypertension that is not well controlled is contraindication, nasal congestion, or headaches. So whenever these patients are on this medication, we make sure that their blood pressure is well controlled and there is no evidence of bleeding from the nose. With respect to anticholinergic medication, currently it is rarely prescribed in Europe because of it increases the risk of dementia or other cognitive abnormality. So this is no longer popular in use. In this part of the world, in UAE, we also don't use this medication anymore. So these are just expert recommendations concerning anticholinergic medication and possible effect of dementia, just to per se. Approach to anticholinergic medication, if we have to prescribe this medication, we want to avoid, we want to make sure we reduce the dose in people that are above the age of 65. We do individual counseling, behavioral therapy, and also we minimize the risk. But generally, in most people that are 65 years of age, we tend to go to beta-3 agonist medication. Several studies have been done in the past whereby they compare the behavioral therapy and drug therapy, and essentially the antimuscarinic that were used were found to be as good as placebo sometimes. And this graph kind of illustrates that the lower level here shows the reduction in incontinence, which is common with behavioral therapy. So essentially, in summary, for treatment of urinary incontinence, we evaluate, we diagnose, lifestyle modification, and we reassess. If all these things fail, then they need to be referred for a specialist treatment. And we normally see these people for abnormal evaluation, complicated incontinence, which people with previous infection, hematuria, blood in their urine, hematuria, and whenever there is a significant voiding problem, or people that have history of previous pelvic floor surgery or radiation or suspected fistula. And for people that have overactive bladder or urinary incontinence that failed the medication, there are 3 lines of thought. We can do Botox injection into the bladder, and we can also do stimulation using the peripheral nerve block of tibial nerve. And the last thing we normally do, we call sacral nerve stimulation, which I will show you the picture shortly. Over here, refer to the surgical therapy of overactive incontinence. To my right side here is the cystoscopic injection of Botox. And the drawback to this is that the side effect can cause urinary retention for a few days, usually for 2 to 3 days after the procedure, in which case we leave an indwelling catheter. And the second drawback is usually the Botox wear out in 4 to 6 months, and patient will have to come back for the procedure to be repeated. Over here is what is called percutaneous tibial nerve stimulation. Behind the medial malleolar, a needle is placed, and there is a small electric current generator. Usually, patient come for this procedure for 30 minutes once a week. It is done for 8 weeks, and after 8 weeks, it's done once a month for as long as patient wants. The cure rate with this procedure is about 60 to 70%. So we normally start from Botox into the bladder, and if patient cannot tolerate coming every 6 months, we go into percutaneous tibial nerve stimulation. The last hope is the sacral nerve stimulation. This is done like a 2-stage procedure in the office. Initially, there's a text procedure whereby electrode is passed through the back, through the S2 foramen to stimulate the sacral nerve too. And there's a small generator battery that is connected. We normally look for 50% reduction after the text, during the text therapy, which usually for about 4 days. And if patient respond appropriately, the battery can be placed over the gluteal region in the operating room. There are other non-surgical therapy for stress urinary incontinence, like use of vaginal cones, pessary, and sometimes we have a urethra plug, whereby the woman will insert the plug in her urethra, and whenever they want to either exercise, go to the gym, or run marathon, they can put the plug, and after they finish the race, they can remove to go and pee. For stress incontinence that failed conservative management, there are other surgical interventions we can do. We can do surgery like mid-urethral sling, or we can inject some biomaterials around the bladder neck we call urethral bulking agents. So this picture shows periurethral bulking agent, and this here is the bladder, and this is the cystoscope coming from through the urethra, and these are the bulking agents that are injected across, at the bladder neck. When you look at this picture, this is how the bladder neck was wide open before the injection. These are as the substance is being injected around the urethra, the opening is kind of closed until you get to what is called adequate coaptation on the right side here. For the purpose of a sling, this is a minimally invasive procedure that is done as an outpatient basis. The slings are usually made of polypropylene mesh, and they are inserted in the bladder through a small tiny incision, just for the urethra to sit on to rest on the mesh, so that during coughing exercise, patient will not experience urinary leakage. And when all these fail, there are other invasive procedures we call bulge couple suspension, whereby a lower midline incision is performed, just like cesarean section, and the bladder neck is kind of tied down behind the symphysis pubis. So this can be done through the autologous fascia or cadaveric fascia as well. So in conclusion, urinary incontinence is common and bothersome to women. It could be stress, urgency, and mixed incontinence. They are non-invasive therapy for both stress and urinary for OAB. Behavioral and pharmacological treatment are also effective in some patients. And for complex cases that are refractory to treatment, we always advise people, either a general OBGYN or family physician to refer to a urogynecologist. Thank you for time.
Awesome. Thank you so much, Dr. Babalola, for being present. Unfortunately, you cannot see him because of technical difficulty. Again, like he said, he's zooming in from Australia, lining from UAE. Thank you again, Dr. B. We miss you in the United States, but I'm sure those in UAE are excited to have you. Please, can we have all two participants present on the stage? All right. Thank you so much, Dr. Hella, as well, for being here. Do you guys know we have a lot in common, all three of us? The commonality is we all lived in Michigan.
I think that's crazy. And you and I met in France?
Yes, I met Dr. Hella in France, and we connected because we all identify as coming from Michigan, so we're Michiganians. And Dr. B also lived in Michigan. At that time, he worked in Beaumont. So we're all here representing Michigan. Yay. Awesome. Again, thank you all for being here. The topics today were very, very important. Definitely hot topics in women's health. You talked about the ectopic pregnancy. Thank you for emphasizing the fallacy of doubling, because a lot of us still read that in some textbooks. But thank you for highlighting that progesterone should be drawn as well. So my question for you is, does progesterone level change with increasing pregnancy, or it's a one-time thing? You check, it's less than 5, you're like, non-viable, ectopic. Walk me through how you see it, talking about the gestational age as well.
So the progesterone level goes up because of, so whenever we think about progesterone, we have to remember the physiology behind why progesterone is there. What is it doing? So we know, of course, that once that corpus luteum cyst, once we have that corpus luteum cyst and we have a fertilized egg, that's where the progesterone is being produced. Whole point of it, of course, is to allow for placental formation, blah, 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 blah. So it's got to go up. It's got to go up to support the pregnancy. So when you first have that very first ACG, say your person is 4 to 5 weeks pregnant, and you get that first ACG, and your ACG is like 54,000 or 100,000. Well, for a viable pregnancy, it should already be on 20 and above. So if you have an HCG of a normal appearing ACG, but your progesterone is 5, that's not right. So if you go back and look again, so say you know how they do I say they because I don't do it. I personally am a needle phobe, so I won't do to people what I don't do to me. So I don't do that every 2-day blood draw thing. What I do is like I do it every week or every 2 weeks, depending on what I'm concerned about. So if I do that first one and the ACG is 54,000, then we go back a week later, the ACG is maybe 74,000. Well, that already lets you know it's not right. But if you do that confirmatory progesterone, usually it's still around 5. On the flip side, if it's normal, you do that ACG the first time around, progesterone should be, say the progesterone is 15, which is in our kind of warning. So you go back a week later and it's gone up now to 20. Okay, you know that we're safe. So it does increase depending on the health of the pregnancy and how much placental mass you have.
Wow. All right. Thank you so much for clarifying. Dr. B, Dr. Babalola, you touched a very important topic, urinary incontinence. I don't know if you guys know of this, but I'm starting a workshop called Loving Your Menopause.
Oh, okay.
Yes. Yes. We got to love. I'm not there yet. Okay. I'm not there yet.
I am.
But, okay. Okay. Thank you, Dr. Ella. Okay. So we have to help women love their menopause. Like, it's a different phase of their lives, but it's an important phase. You don't just stop living because you stop menstruating. You're still important. Your knowledge is still important to the society. So we're trying to make you optimistic and enjoy your menopause. And urinary incontinence is very important because when you pee on yourself, you see that in pregnancy, right? A lot of patients don't talk about urinary incontinence in pregnancy, but I always whisper to their ears, when you cough, you pee, right? They're like, yes, doctor. I'm like, yes, it happens. Don't feel bad. It's common, but we'll keep it quiet for all of us. Anyhow, the same way as a woman gets older, they are not comfortable having incontinence. So thank you so much for making it common and letting women know that they're not alone. The data you provided said 30% of women over the age of 65 do have urinary continence. Women listening, surgeons listening, that's 3 out of 10 women. It is common. But
Yes.
I'm so happy that we have solution to that situation. Thank you so much, Dr. B, for going through all of the different management plans because some patients are scared of going through surgery, like doing the sling, but you showed us that there are many ways in managing that. Um, Now that we have other alternative, like you talked about, let's see my notes. You talked about the PTN, right? The stimulation, the percutaneous tibia stimulator. Like now that you're doing that, are there less sling placement or birch surgeries going on?
In the UAE, one of the problem we have is similar to the United States of epidemics of obesity.
Mm-hmm.
So in the last 2 years, what we do is a comprehensive care of women, not only their bladder, their overall health. There is a clinic here we call La La La, which is Arabic word for a well woman.
La la la.
So what we do is that not only when we start with conservative treatment for incontinence, they are referred to dietitian for weight management. And majority that has a significant weight drop, they find their incontinence improve. So the frequency of invasive surgery like sling or butt couple suspension has actually gone down. And in addition to that, when we go to the stage of very severe overactive bladder and the percutaneous stimulation is not working,
Mhm.
now that we change our language, like the sacral nerve stimulation,
Yes.
I always present it to them like, listen, if your heart is failing, people give you a pacemaker.
Exactly.
This is a pacemaker for your bladder.
Yep.
Wow.
And they say, wait a minute, doctor. So is there a pacemaker for the bladder? Yes, there is. And after the initial test stimulation, they discovered that instead of waking up like 5 times a night, one woman came to me. She actually didn't wake up at all. She slept through for first time in the last 10 years. So after 2 days, she came right up to the office. I need it now. Insert the pacemaker. So there has been a change, and I think it's due to education, spending, one-on-one time with them.
Wow.
Well,
Thank
but
you. Oh,
I'm
go
sorry,
ahead.
but I also think the issue is it's gotten better. So when the STEM first came out, I was a student back when the STEM first came out. I feel like when that first came out, the issue was there weren't very many people who put it in. The ones who put it in didn't have the best in regards to the efficacy rate, depending on who put it in. And of course, myths start in the community. So and people get afraid of it. When you talk about putting anything by your spine, people are going to freak out. So
Yes.
do you think that one reason why it's gotten that it's getting better is mostly because of the improvement in the skill of those doing it, the fact that we narrowed the scope of who can do it. So now you can only do it if you're a guy for the most part. Or do you think it's because we just do have a better communication around the fact that there's so many more alternatives than just ripping out uteruses and putting people to surgery? Like, what do you think?
Okay, in my experience, I practiced between 2019 and 2022 in Texas before I moved here. And one of the things I noticed in Dallas area is communication.
Mm.
And secondly is the issue of if you are not qualified, not people that do a weekend course to insert it, people that are actually board certified, fellowship training, they are the one allowed to do those procedures.
Mm-hmm.
So we have a selection of provider who actually put the pacemaker in for the right indication, not every comer. Now, to give the credit to the company that makes these devices, the technologies has really, really advanced.
Yeah.
Now we now have some microchip. Before we used to, put it in every 2 years to go and remove it, and people were scared.
Mhm.
Well, now we have some long batteries that last for 7 to 10 years.
Oh,
That's
okay.
that's one. Secondly, we now have some batteries that are actually rechargeable, like a cell phone.
Like the
So
contact.
after you put it in, if they don't use it, you give them something like a remote control, which is just like a Samsung or Apple phone. They turn it off, and they can actually look at the battery life on their remote control. So let us say the battery has spent 3 years and it's like 40% used. You can turn it off, charge your device where you are still wearing it remotely for say 3 hours, and the battery life will go up to 100%. So there has been improving technology, improving technique of placement, and more importantly, adequate selection of the providers.
Wow. Wow. Thank you so much for the explanation. You know what? Talking about this topic, urinary incontinence, kind of makes urinary incontinence like sexy and not something that has stigma attached to it. So thank you again. We do have a question from the audience. Is for Dr. Hella. Dr. Hella, I don't know if you had the chance to read it, but this question is in regards to ectopic pregnancy. The question states, is there increased maternal mortality due to ectopic pregnancies in states that have no exception laws?
So I'm assuming what you're asking is, since we lost Roe v. Wade, and we're dealing more with more and more very restrictive laws regarding abortion.
Reproductive. Yeah.
Yes, so we've already seen it. Texas, and not too long after Roe v. Wade went down, Texas had a case of a woman, like at least that same week, a woman who had an ectopic, who almost died. Like it took it to the very edge before they finally treated her. And that was great because it helped to show people, hey, there's a problem, but it wasn't enough to make the state legislature reverse course. And so since then, we have had more women pass away from ruptured ectopic pregnancies here in the States, specifically in those 10 states in the South who had the trigger laws, where as soon as Roe v. Wade was overturned, they triggered to those extreme laws. So yeah, it's already bad.
Wow. Wow.
And I think one reason why is because I still hear people say, well, can't you just move the ectopic into the uterus? So I feel like people who don't understand science should not be making these laws. You can't just squish an ectopic from a tube into the uterus. It doesn't work that way, right? And I think that there's a belief, I've heard the belief that some legislatures in some states, Tennessee specifically, that said that as physicians, we are refusing to do this. Like, we can do it, but we just refuse to do it. And that's not true. It's impossible.
Wow. Well, thank you. Thank you for that. Dr. Babalola, one final question before we wrap up. You know how, in terms of loving your menopause, people are using Botox for their face to help with wrinkles and just to promote living your best life. Can people prophylactically inject Botox into their bladder to prevent urinary incontinence? Like when they get it for their face, they're like, okay, let's get some in our bladder.
Unfortunately, absolutely no, because the indication for using Botox in the bladder is very strict and is very guarded.
Okay. Yeah. I have a question about that too. So when you use Botox, how long does it last, and why do you have to do the left ureteral opening and not the right?
Well, it lasts for, on the average, 6 months max. Some people 3 to 6 months.
Okay.
Yeah. So the second question, why do you have to do on the right, not the left? Is that?
Yes. Yeah, the left on the right. Yeah, left and not the right.
Well, we can do it. My own guess is most surgeons are right-handed.
Okay.
Gotcha. Okay.
And it's very, because you are doing this thing, you are doing hand and eye coordination. And it's a very, very small layer. You have to be careful. Okay. You don't want to go too deep, and you don't want to go too superficial.
Thank you.
Thank you. Yeah. All right, we're going to wrap up since we have no more questions. Please, our speakers, do you want to put your information in the comment section so that people can reach you. You guys are so amazing. This was an excellent webinar. Today, we reviewed the management of ectopic pregnancy and urinary incontinence. We learned about the fallacy of doubling. Do not use beta HCG doubling. And instead, we learned to use progesterone levels as well to determine if this is a viable pregnancy or not. We also see the cost of urinary incontinence, how expensive it is. We also saw how to manage it. Special thanks to our presenters, Dr. Heller and Dr. Babalola. A special thanks to our planning team and the ICS-US family for joining. A special thank you to Dr. Ahmed Joy, the executive producer of this ICS webinars. We hope our listeners will join us and become a part of this great community by going to our website on the screen. Our website should be on the screen, but it is www.ficsonline.org. We hope to see you guys later. Thank you again. I appreciate everyone. Goodbye for now.